Welcome everyone to this installment of the ongoing UVA Department of Radiology and Medical Imaging Keynote Series. We've got a very interesting and exciting scientific presentation today by Professor Colin Derdeyn, who is a world-renowned neurointerventionalist, chairman at the University of Iowa, and imminently the incoming chair at the University of Virginia. If I review his CV and background, it would take the entire evening and not leave any time for lecture and questions. So let me just hit a few points for you. Did his residency at the WashU and Barnes-Mallinckrodt Institute after graduating at UVA School of Medicine. So coming back in a full circle over here, 2 fellowships, diagnostic neuroradiology, stroke, cerebrovascular research, a fellowship in neuroradiology and interventions, spent 20 years as faculty at the Mallinckrodt Institute, and then as chair at the University of Iowa, led their biomedical imaging, a renowned and phenomenal institution. I've seen it. Served as president of the Society of Neurointerventional Surgery and also the chair of the AHA Stroke Council. Enormous grant success with just one thing to note, in particular, a 10-year, $100 million partnership with Siemens for imaging and collaborative research. So we're very excited about what that's going to bring to UVA as well. But to tonight's topic, we are talking about the latest in carotid interventions specifically. And with that, the stage is yours. Professor Colin Derdeyn, welcome.
Thank you, Ziv, and thank you all of you for your interest in tuning in and listening to what I've got to say here. And I really am, I haven't updated any of my slides yet because I'm still being paid by the University of Iowa, which is where I currently am, and in a weird little limbo here before I get started in Charlottesville. And I am super excited to be back at UVA, and it's a great place with a lot of good things going on, and to work closely with you, Ziv. So this talk is it's a data heavy talk. It's a lot of clinical trials information, but I think it really informs current practice. And this is a disease that we see a lot of. There's a lot of excitement about new technologies, TCAR, different iterations of carotid stents, and it's really important to know what the level of evidence for these procedures that we consider for our patients. And so hopefully you'll walk away with something new at the end of the talk, and there'll be time for questions as well. I do have some conflicts. I was the chair of the DSMB for the Roadster trial and the current NIGHT trial for Silk Road, which is the company that makes the TCAR device, and also a DSMB for an aneurysm study with microvention that also makes a carotid stent. In terms of objectives, the most important thing, in my opinion, is recognizing how critical ischemic symptoms are in determining whether or not somebody is going to benefit from revascularization. And the symptomatic patient population is radically different than the asymptomatic one, even though their angiogram may look the same, their CTA may look the same. It's a very different beast in terms of procedural risk and outcomes with therapy. And then there are a lot of other factors too, which are super important to throw into the bucket when you're thinking about whether or not to recommend intervention. And that is going to be gender, the timing of the procedure relative to symptoms, how old the patient is. There's some really fascinating aspects about age that I'll dive into a bit, and also the degree of stenosis. And then finally, just more broadly, understanding the role of intervention for carotid stenosis. This is the outline I'm going to follow. I'm going to speak just very briefly about stroke epidemiology and the association with atherosclerotic carotid disease, and then bucket out the symptomatic and the asymptomatic data. So this is an ex vivo specimen from a carotid endarterectomy. This was the carotid, common carotid, the internal and the external. This is this dissected intima, which is laden with this big atheroma. and then this very grumous-looking plaque with a lot of debris and a lot of other things. And it's easy to understand how this can be a cause of embolic stroke. This is not a normal, healthy endothelium. Clot can form on here, it can break free, and it can cause an ischemic stroke. Up to 40%, depending on where you are in the world or the nation, of patients that have carotid territory TIA or stroke have a severe stenosis of the carotid, and complete occlusion is common as well. And then also too, you can have isolated or concurrent cardiac sources as well. In terms of why patients get stroke, certainly embolic factors are primary, and that last specimen really shows why that is the case. And there's a lot of empiric evidence for this too. If you look at people that show up with symptomatic carotid stenosis, a lot of times you'll see emboli in distal vessels. There'll be retinal emboli if you look in their eye fields. And with transcranial Doppler, you can frequently identify silent emboli that are distal to a symptomatic carotid. And it's also important to note, and I think this may become more and more important in the asymptomatic population, but coexisting hemodynamic impairment, poor collaterals, is a powerful and independent risk factor for stroke as well. And it's probably synergistic. Most of the strokes for patients that have hemodynamic risk are probably embolic strokes that just don't lyse quickly, or that brain is already maximizing all of its compensatory mechanism, and something which might be a TIA in a good, healthy patient may be a completed stroke in somebody who's sucking every molecule of oxygen they have to try to compensate for low flow. And this is an area that I've spent a lot of my career in, and I could spend the whole talk talking about it, but that's as far as I'm going to go. So one slide only about medical therapy for carotid stenosis. And the reason why is we don't know much. Nearly all of the primary or secondary stroke risk reduction interventions, meaning primary meaning somebody who's completely asymptomatic, and secondary meaning somebody that's had a recent TIA or stroke. Nearly all the data we have are from large trials of all comers. And in general, patients with carotid stenosis were often excluded from these studies, or if they were included, they were unknown because nobody looked at the carotid. So we really don't know what the relative benefit is of antiplatelet or other forms of risk factor reduction. But in general, what we recommend is standard risk factor reduction, which is smoking cessation, a statin, antiplatelet if you're symptomatic, control of diabetes. There's some interest, people have proposed repeating a trial randomizing to a medical arm in patients with symptomatic carotid stenosis because of the apparent impact of more aggressive medical management regimes like dual antiplatelets and aggressive statin lipid lowering regimens and aggressive treatment of hypertension. But that is unlikely to ever get off the ground, because I think that the magnitude of benefit of intervention in a symptomatic patient population is so large that people aren't going to be comfortable randomizing to a medical arm. But it is important to be aware of that. So the three treatments I'm going to talk about now that we've disposed of medical treatment, it's stenting, TCAR, and it's endarterectomy. And they are very different procedures. They share some common features, but they're different in other ways. And so it really is, it's apples, oranges, and pears. And I'll try to pull that out here through the course of this talk. So carotid endarterectomy, for those that haven't seen this is an operation that's been around for a long time, 50, 60, 70 years. An incision in the neck, identification, ligation of the common carotid, and then internal and external so you can control it, and then opening up the internal and shelling out this plaque like we saw in that last specimen. And this is a procedure that can be done very quickly, 30 minutes, an hour, in a really simple, uncomplicated case. With and it's been extremely well studied. And a lot of the data that I'm going to show is really about carotid endarterectomy, because it's kind of like FDA and 510King of devices. The predicate is carotid endarterectomy. And a lot of the interventions like stenting or TCAR are not being compared or proven against medical therapy. They're being compared to carotid endarterectomy. And so knowing what that data is for endarterectomy is really important for understanding what the magnitude of benefit is with these other interventions in these different patient populations. This is an example of a carotid stent case. And incidentally, this is with the Parodi device. And that's actually a tie that binds Ziv and I, where for 10 years we served together on the scientific advisory board of Gore. And Gore had bought this technology from Juan Parodi, which it never fully brought to market, but it was a balloon guide protected with a balloon in the external, isolating this circulation so that you could do an angioplasty and drop a stent off, all with flow reversal with a circuit coming back in the leg, which is interesting because that's really what TCAR is doing too. And so the differences between transfemoral carotid artery stenting, which is generally done with a guide cath and a distal protection device, not flow arrest, but you can. Those opportunities exist. And then finally, TCAR, this is just a cartoon where there's been a surgical exposure of the common carotid. There's been a sheath placed percutaneous, well, not percutaneously, under direct visualization, a balloon that's inflated here, and then a circuit that allows for retrograde flow to come through a filter back into a common femoral vein. And so then this procedure is done with reversed flow to reduce distal emboli during the course of this procedure. So TCAR, transcarotid artery revascularization. Stent technology, things aren't static in any of these spaces, except I think for endarterectomy, probably a bit static, but there are all kinds of iterations in terms of better distal protection devices like these filters. There's really a big role likely for covered stents because it traps the debris intraprocedurally and post-procedurally, which is probably a big source of microemboli. And then also, like I mentioned before, a balloon guide catheters, flow reversal. There's all kinds of different ways to bring technology to bear in this disease. Okay, let's talk about data now for symptomatic patients. The big trial in our space, so in our world of vascular neurology, cerebrovascular disease, the second randomized trial ever done. The first one was the ECIC bypass trial, but then the same group in London, Ontario, organized NACIT on the heels of the ECIC bypass trial. And this was a randomized trial of surgery versus high-dose aspirin for patients with symptomatic carotid stenosis, TIA, amaurosis, fugax, or stroke. And endpoint was any stroke or death. And the result was a massive risk reduction with surgery. And this next slide, this is about NACIT here. This slide here is just reminding me, for those that don't pay close attention to this area, how we measure stenosis. And this is really important. So the NACIT criteria, the North American Symptomatic Carotid Endarterectomy trial, it took the tightest linear diameter of the plaque, of the tightest stenosis, either in the APE or whatever projection was the tightest, and measured that as a fraction of the normal distal lumen, B. And this is somebody here who has a big honking plaque, but really no measurable stenosis. And then this is somebody with a very, very tight stenosis where A over B is going to be, 10%, which gives you a stenosis of 90%. And then this is the overall data. So this was the NACIT data plus the European trial, the ECST. And Peter Rothwell was a Scottish vascular neurologist who went back and remeasured all the European trial data with NACIT criteria, and then pooled all the data sets. And there's a lot of rich information from this pooled data set. The first is, here is the 70 to 99% patients. This every year here this is a year, so it's out to 10 years. These are 10%, 20%, 30%, and this is the hazard curve. So this is a 10% risk of stroke or death, 20%, 25%. And what you see is the heavy curves here are the surgical group, and then the light line is the medical group. So within the first few months after a slight perioperative complication rate, these curves cross, and there is a massive absolute risk reduction here that's persists out to 10 years. So endarterectomy in a symptomatic patient with a high-grade stenosis has numbers needed to treat that are better than anything else on the planet until stroke thrombectomy came along. You know, this is these are enormous benefits. A benefit for the less severe patients, symptomatic patients with 50 to 69. The curves cross later, close to 2 years, but they separate and they stay separated. So there's a benefit for patients with 50 to 69% stenosis. Once you get less than 50% stenosis, and I saw a tweet recently, like somebody pointing out that, you know, that carotid atherosclerotic disease, you know, causes strokes even if the stenoses aren't severe. And I was a little worried that the person was advocating, so therefore we should treat them with stenting. And I didn't pursue it to know whether that was the case or not. But the evidence is pretty clear that if you perform surgery to remove this plaque, there is not a benefit if there's less than 50% stenosis. And less than 30%, pretty obvious that there's harm. Near occlusion, I'm going to come back to in a moment. It's a special category. The numbers are small here. So near occlusion was the category that they used in NASIT when they couldn't measure it with NASIT criteria. So if the internal carotid artery lumen is collapsed from low flow, you can't measure this stenosis as a fraction of that. And the other criterion was that extracranial vessels fill before the intracranial because of the high resistance circuit. So this is called near occlusion. And what we found in NASIT was that the near occlusion patients, they behaved a lot more like the 50 to 69 than the 70 to 99. The numbers are low, and this is not a primary endpoint of the trial. There is possibilities that a lot of these patients were treated outside of the trial, but a near occlusion, even in a symptomatic patient, is really not necessarily an emergency for getting their endarterectomy done. And I think a lot of people are a little more circumspect about whether or not to treat them and take this into an account in terms of other comorbidities and risk factors about whether or not this is somebody that you should treat, because they do not appear to behave like the high-grade stenosis. And there's an interesting story there. You know, some people think it's because since the flow is so low, there's less embolic risk. And then there's also some potential that if that you only collapse your lumen and get into a low flow regime if your collaterals are really good and you don't need your carotid anymore. So it may be that these patients have lower risk from hemodynamic factors or lower risk from embolic factors or both, but whatever it is, they seem to have a lower risk of stroke on medical therapy than the 70 to 99% patients. Okay, the other thing which I mentioned earlier too that's important to bring into the story is gender. And the interesting thing here is that women with symptomatic carotid stenosis appear to have less benefit from this procedure than men. This is patients with, these are absolute risk reductions. So you take this is 30-day perioperative stroke plus subsequent ipsilateral stroke out to 2 years. The absolute risk reduction in men with 50 to 69% stenosis is about 8. So about 8% absolute risk reduction, really large. 15% for the higher grades. For women, this is the point estimate. These are 95% confidence limits. For women with less than 70% stenosis, there may not be benefit for endarterectomy. These are post hoc subgroup analyses, but it's important to keep in mind when you're looking at these patients. Higher degrees of stenosis clearly benefit, but less for women than for men. And then if you drill down for why that might be, and these are not statistically significant, but again, these are the pooled data from NASIT and ECST. Women tend to have higher complication rates with the procedure, with endarterectomy, and they tend to have lower risk of ischemic stroke on medical therapy. And that's probably those two factors contribute to why women appear to benefit less from revascularization than men. And then this slide here, which I really kind of enjoy, it takes a while to get your head around it, but now we've talked about degree of stenosis, we've talked about gender, and now we're going to talk about timing, okay? So here's time from their qualifying event to when they were randomized, which is really right about when they were treated. And so if you got your last TIA or stroke was within the last 2 weeks, and then you got your carotid treated, this is male and then this is female. For men and for women, great benefit. These are absolute risk reduction again, over 20%, 40% for women down here. If the gray is high-grade stenosis, the white is 50 to 69. And for men, I'll just work my way across there. For men that have high-grade stenosis, there's a substantial benefit even all the way out to 3 months after the qualifying event. It seems to diminish with lesser degrees of stenosis. For women, dramatic benefit within those first 2 weeks that really is rapidly lost for both high-grade and the less severe stenosis. And then finally, the last thing I want to throw in is age. And this is an important factor, a really important factor, especially when we get into TCAR and CAS, because there really does seem to be a difference between these procedures with risk to patients based on age. And it could be modifiable with devices, and I'll get into that. But this is all patients, absolute risk reductions. Again, these are subtracting what the risk was on medical therapy from the risk in the surgical group, and there's over a 12% absolute risk reduction for perioperative and postoperative stroke for all comers. This red is 75-year-old patients. This is less than 65, and this is 65 to 75. The trial's limited enrollment over 80, so this is actually just 75 to 80 years old. But this is altogether, this is the lower grade stenosis, this is the higher grade stenosis. And what you see is the older you are and the tighter the stenosis, the more you benefit. So even though older patients are going to have higher risk from a surgical procedure, their benefit is greater because their recurrent stroke risk is so much higher. So age is not a reason not to treat. If anything, it is a reason to treat these patients that are with symptomatic carotid stenosis. So summing up the CEA data for the symptomatic patients, for men, 50 to 99, for women, 70 to 99 for sure. Don't delay, especially in women, in terms of how recent their symptoms are. And older age is not a contraindication. These are level 1 class A evidence for endarterectomy for symptomatic stenosis. And important to note that a lot of this evidence that I'm talking about for gender, timing, near occlusion, they're post-hoc analyses. And I use them to guide my treatment decisions, but guidelines aren't going to put strong recommendations on what I just covered. But the data is pretty compelling. Okay, stenting. The problem with the stenting literature is that most of the trials, for a variety of different reasons, lumped symptomatic and asymptomatic patients together. And that's a problem because the risks of the procedure are probably different in those two different populations, and the benefit may be different as well. So, and I'll get into some of the controversy that comes with it, but that's, and the second problem in addition to lumping is that these trials included MI as a primary endpoint, and the endarterectomy trials did not. And there's controversy about how disabling the MIs were in these trials, and that's an issue. And the first big trial that came along was the CREST trial, and that's what this is here. And the CREST trial found essentially equivalence, or at least non-inferiority between carotid stenting and endarterectomy in a mixed patient population with an endpoint that combined MI with perioperative stroke or death or ipsilateral stroke during long-term follow-up. Now, these are the 4 trials that have been done, 4 randomized trials that have been done that have included symptomatic patients and randomized them to stenting versus endarterectomy. And these 2 were symptomatic only. These were mixed asymptomatic, and they were not designed to test symptomatic or asymptomatic separately. It's all together with a pooled endpoint. So these are numbers that have been pulled out, and they do represent subgroup post hoc analysis with a lot of caveats. But what you can see with these 4 trials, if you look at, these are the CAS and CEA, design non-inferiority, death rates, death and stroke rates, and then including MI. So for example, CREST here, we've got, this is our number of patients with stenting. This is the number for endarterectomy. The risk of stroke and death was 6% in stenting group, 3% in the endarterectomy group. But when you add in the MIs, these become very close to one another. And that's where we get at the heart of the debate. It's what do you worry, what bothers you more, an MI or a stroke? And how equivalent do we think those are? And again, the primary, this kind of gets a little legalistic in terms of how trials are, but the primary endpoint of the trial showed non-inferiority of the 2 of stenting versus endarterectomy, but mixed asymptomatic and symptomatic, and including MI as a subgroup. So there's unanswered questions, but clearly across all of these trials, higher rates of stroke in with at least the devices and the technology of endarterectomy 10 and 15 years ago. Now, I'm going to come back again to the age thing because I think there's a lot to it, and I think that it's an opportunity for TCAR and for stenting. And this is, we talked before, these are adjusted hazard ratios, and this is using pooled data from those 4 trials that I just showed you from the stenting trial versus endarterectomy. For endarterectomy, this is age, up to and exceeding 80 years. And for endarterectomy, there's no increase of risk with age for that procedure in terms of stroke risk. Okay, but then as we look with stenting for both, well, as we look at stenting here, you can see how these do increase with age. There is a higher risk of stroke with stenting as you get older. And this is the next related slide here. So now what we're looking at here is it's this idea that age may be a surrogate for microvascular disease, small vessel disease, and that the older you are, the less able you are to handle a shower of microemboli and more likely to exhibit stroke-like symptoms from that. And this is looking at the different white matter injury scores and dichotomizing here by 7, and then looking at, it's relatively small numbers here, but these are patients with stenting, patients with endarterectomy, and then here in blue, the numbers showing the much higher risk of stroke in patients that were stented that have higher white matter abnormality scores for any stroke, for non-disabling stroke, and for fatal disabling stroke. So summing up the symptomatic stenosis, I'm going to pull in TCAR later because TCAR really doesn't have any directly relevant randomized trial data to bring into this, but I'll talk about the technology at the end. But for a good surgical candidate, we have a level 1 evidence for CEA. We have CAS that's been proven equivalent. And I think for patients with a high operative risk, it's definitely the way to go. Anatomy, MI, those are things definitely to think about, but I wouldn't include age as being a factor for pushing for endarterectomy over stenting. And microemboli may really be the biggest challenge we have. And coming again to TCAR, this flow reversal and ways to protect against the shower of microemboli or covered stents may have a role to play in making stenting safer in this patient population. Okay, so now I'm going to shift gears and talk about asymptomatic patients. So coming back to kind of ground truth again, we're going to talk about the endarterectomy trials because that's what's proven that there's a benefit for revascularization in this population. And there have been two, the ACAS and ACST, and both of them showed a benefit for endarterectomy in this patient population. However, and I'll get into this in later slides, these trials were done 20, 25 years ago, and the risk of ipsilateral stroke in an asymptomatic patient back then was 2% per year, and it's probably lower than that. And there are ongoing trials that are ongoing right now, CREST-2 and ACT, and well, actually, CREST and ACT are the non-inferior. I'll get into the trials that are going in later. But again, just like we had for symptomatic disease, we have non-inferiorities for CAS in this population, and that's CREST and ACT. So a word about ACAS, just like we started with NASCET, randomized trial of surgery versus best medical therapy, published almost 30 years ago. Asymptomatic patients, greater than 60% stenosis, endpoint any stroke or death, and there was a small risk reduction for surgery. So a 1% annual absolute risk reduction. And you compare that to what we showed for NASCET, which had 10, and 15% annual risk reductions for surgery. I mean, just a very, very different magnitude of benefit in these two populations. And then interesting subgroups again. So this again is, I've got two slides on subgroup. This is what the ACST, which came out in Lancet about 10 years later. And it showed a benefit overall, very similar to ACAS. However, women appeared to benefit less, and I'll get into this more with pooled data later. Older patients tended to do worse. This is anything that includes one is something where there's surgery's not better. And this is clearly surgery better. But so older age, and then the other thing that was interesting is that tighter degrees of stenosis did not appear to indicate higher risk on medical therapy for asymptomatic patients. For symptomatic patients, it does. We all worry about a stenosis when it's tighter, then it's not with an asymptomatic patients, but the data is not that strong that it means anything. And this is some of the best data that we've got. Then coming back to gender again, this is our old friend Peter Rothwell again, that pooled data from NASCET and ECST, and now he pooled data from ACAS and ACST. And here he's looking at gender. And for men, these are events in the surgical arm, the medical arm, the odds ratio. These are the combined odds ratio here. Really a very strong benefit for asymptomatic men with endarterectomy. And for women, pretty clearly no benefit for an asymptomatic woman. Now, this is not the primary endpoint of the trial. The trial was men and women, and it was positive for a benefit. But some of these subgroup analyses are really compelling, and this is the same story that we're seeing with symptomatic disease too. Gender has a big impact on the medical risk and the outcome with intervention. Okay, these are the non-inferiority trials where, and it was really these asymptomatic populations in CREST that drove the benefit overall. So in CREST, many more asymptomatic, actually about the same number of asymptomatic patients, but the outcomes were very similar here. Any stroke or death, 1.4% for endarterectomy, 2.5% for CAS. When MI comes in, there's actually an excess, at least in terms of the absolute number here, the point estimate. And then including greater than 30-day stroke, the long-term outcomes, very similar outcomes with angioplasty and stenting in the asymptomatic population. And it's very similar with ACT. And this is what I mentioned at the beginning. These are, this is a slide I got from Ann Abbott, who's been a real crusader for this topic. But these are the risks of any stroke or ipsilateral stroke in clinical trials for asymptomatic patients. So some of these numbers are like, this is like one here is going to be the ACAS trial, where it was a 2% annual risk for stroke. But as you go to the right here, these numbers really do seem to be much, much, much lower. And this is probably because of better risk factor management. And this may negate a benefit for revascularization in an asymptomatic population. And there was a early publication or a presentation of data at the European Stroke Conference with the ECST2 trial, which is the randomized trial of surgery or stenting versus best medical therapy for asymptomatic patients. And at 2 years, the risks were the same. The curves had not crossed. The stroke risk is really high in this population, and I don't know why that is. It should be like about a 4% risk in both groups at this point, but at any rate, not equivalent so far. And then I think the CREST-2 has finished enrollment, but it has to go through long-term follow-up. And CREST-2 is any intervention, surgery, carotid CAS versus best medical therapy in an asymptomatic population. So hopefully in the next year or two, we will get some good data on what the modern outcomes are for medical therapy and intervention in an asymptomatic population. So I'm going to talk about TCAR now. TCAR is kind of a disruptive technology. There are some advantages to TCAR. You avoid arch manipulation, you have control of the carotid, and you can reverse the flow. And there's a great deal of enthusiasm for it in vascular surgery primarily. And because they do carotid endarterectomy, and this is right in their wheelhouse. So, but the data for it, there haven't really been any head-to-head randomized trials yet. There's one of the issues that this issue of vascular surgery, or J-vascular surgery about 3 years ago, was completely devoted. All 20 articles in it were from the SVS VQI registry related to TCAR. And that's really the biggest information we have. And this was one of the papers that I thought was particularly interesting, but in the registry. And so the registry, you can try to balance for risk factors, but there's all kinds of factors why some people get TCAR and some people get a stent and some people get surgery, and they can have to do with age. It can have to do with comorbidities, access, all kinds of things that make the comparison not as valid as a randomized trial where you can really control for these much better because of chance. But this is one is their equivalent. These are 95% confidence limits. And for stroke and death, comparing TCAR and endarterectomy, and this is by age, very little difference in the registry data between TCAR and CEA. And then they also compared TCAR and stenting, where they found, no difference, although maybe a trend for better outcomes with stenting less than 65 or 70. But after 70, they found this to be statistically significantly better with TCAR over stenting in the older ages. And with stroke and death, the same thing. And again, registry data, not a randomized controlled trial, but again, kind of interesting from a point of view of microemboli and flow reversal and this thing that we see, which is the older patients with carotid stenting do have a higher risk of stroke. This was a meta-analysis that one of our vascular neurologists did at Iowa, where 5 studies that met criteria for good quality, and really none of these were statistically significant in terms of these comparisons. So the jury is out in terms of TCAR being better than either endarterectomy or angioplasty and stenting. I had a couple brief slides about asymptomatic stenosis in patients with really high surgical risk. And I think it's still probably worthwhile to talk about it because there's this, people throw around this term high risk. patients with asymptomatic carotid disease. And usually what they mean is high risk for complications with surgery and not high risk for stroke if you don't treat it. And this was a trial, one of the first stenting trials that was done by Jay Yadav about 20 years ago, where they randomized patients that were at high surgical risk to surgery versus stenting, and they found a benefit with stenting. However, if you look at their 30-day perioperative stroke rates and long-term follow-up, so this is basically I can't blocked up here. These are the absolute risk reductions: ACST, FACR, endarterectomy, FSIR, and stent, showing a better outcome with stenting, but it's still a higher risk of perioperative stroke than an ACST. And then when you combine the long-term follow-up data in these patients, so this is ACST surgical, ACST medical, the stroke rates in these populations. This is the FSIR group that got endarterectomy because they had heart failure, they had radiation, they had all these other factors that made surgery high risk. But it's a 20% risk of stroke at 1 year in that population. And when you compare that to the medical arm of ACST, these are people you shouldn't touch. Stenting was better, but it still wasn't as good as medical therapy. So high risk for surgery in an asymptomatic population pretty much means that you should treat it medically. So to summarize the asymptomatic patients, CREST-2 and ECST2 are going to revisit this question of intervention in the asymptomatic patient population. It's very likely that there's not going to be a benefit given current technologies and approaches. High surgical risk patients, which I just cruised through really rapidly on the FSIR data, they're unlikely to benefit from intervention. And really, where the money is for asymptomatic patient populations right now, it's finding those groups of patients that are at high risk for stroke. And that's probably on medical therapy. And that's probably going to be embolic factors such as plaque biology, or hemodynamic risk factors in terms of how good their collateral flow is. And I think if CREST-2 and ECST2 find no benefit, I think we're going to start to see a lot more attention paid to trying to identify these high-risk subgroups, because they probably do exist. So to sum back up to the objectives we started with, I hope I have bludgeoned you with enough clinical trial data that you recognize how impactful symptoms are in driving the benefit from this procedure. If you've had a recent TIA or stroke and you've got a symptom and you've got a carotid stenosis, that thing needs to get fixed. And in a same patient or similar patient with the same degree of stenosis that's not symptomatic, you have to throw a lot of other things into the bucket to decide what the right thing to do is for them. And those things are gender, timing for symptomatic patients, age, degree of stenosis. They all have an impact. And there's a wide range of options that are open now with endarterectomy, stenting, and TCAR, and even within them, how we do those procedures as well. So I'm really flattered to be invited to participate in this wonderful series that you have, Ziv, and so excited to get to Virginia and to get to work with you and the rest of the team. So thank you very much.
Colin, thank you so much. That was a spectacular review of a lot of dense data. And the good thing is that we've got this recorded, which means we'll be able to come back and watch it again as I have as our other keynotes. There's so many things that come to mind and that I've got questions about. And there are also some questions from the audience that I'd like to get to. You may well want to emphasize the fact that when we look back at the original NASA trial compared to now, two things that immediately come to mind. First, best medical therapy is far different. Yeah. Just the role of statins, dual antiplatelet agents. And secondly, the giant dichotomy between the rarefied results of controlled trials and the real world results, where surgical outcomes have been, in some cases, shown to be 2% to double the complication rates. And how do you factor that in when thinking about the asymptomatic group in particular?
Yeah, yeah, that's a great question. I think, yeah, I think you're right. The question really is about the asymptomatic patients. You know, the 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 medical regimen is that's a tougher nut to crack because the dual antiplatelets, statins, blood pressure control, we know they have massive benefit in acutely symptomatic intracranial stenosis from Sampras. And there's lots of reasons to think that they may have some plaque stabilization roles, especially the statins, as well as antithrombotics. But for an asymptomatic patient population, it's hard to certainly routine risk factor management, but the aggressive medical management, I'm not quite sure what kind of impact that's going to have. But the variability of complication rates, especially when you have a procedure that really requires has such a thin margin, that's a real issue because you really do worry that that there's aggregate harm happening. It doesn't take much to lose the benefit of this procedure if your complication rates are high. And that starts to veer off into things that have nothing to do with science and start to get into the really thorny issues of, you know, how do you monitor, how do you bring people on board that haven't done many procedures and, you know, letting them get experience, and how systems deal with that. That's a big problem.
And maybe I'll bridge from that to the whole question of what do we know about characterizing plaques and the risks of plaques? And I'll capture one of the questions that come up that has been brought up to us by one of our vascular medicines, Professor Sharma, on intraplaque hemorrhage, rim signs, ulcerations, MRI, CT, ultrasounds, and you know, where's our next frontier in that? Is there going to be automated imaging and machine learning that's going to allow us to characterize? Do you want to read into the future for us?
I think those all have promise. I don't know that I would say that any better. You know, the intraplaque hemorrhage by MR clearly has a strong relation to being symptomatic. I think, you know, one of the areas of imaging for sure that is going to indicate higher risk populations are going to be the people that are not, well, where there's ambiguity about whether they were symptomatic or not. And if you can find these factors in the plaque that kind of tips you towards a symptomatic approach, I think intraplaque hemorrhage in an asymptomatic population is probably not very common. But if anything that would indicate instability, an unstable plaque, similar to what people have defined in the cardiac literature, I think that has a lot of promise. I really do believe hemodynamics are going to come into play here. And another thing that I didn't talk about at all, but it's a sub-study of CREST, is looking at hypoperfusion and the impact on cognition, and whether or not that may also be an indication for intervention in these patients. You know, we've all had these these anecdotal experiences of people that think that their executive function improved after endarterectomy or stenting, and but we don't have any objective proof that is a real thing. And so CREST may provide us with that, and that may be that we start doing carotid interventions not for stroke risk reduction, but for cognition.
Boy, that is going to be a messy place to to be offering that and walking that fine line. When I think about, and maybe we spend a minute on sort of approaches as we might all for family or for ourselves have to start looking at differences. There is that large JAMA propensity matched analysis that looked at data for TCAR versus transfemoral stenting that at least in that study, and it was a mixture of symptomatic and asymptomatic, but it was about 5,000, over 3,000 patients that suggested that there was a clear risk reduction in stroke and death if you had the direct transcarotid intervention. And, if it highly cited, looks like detailed analysis would suggest that it puts to bed carotid artery stenting. Yet we've got a recent sort of CMS approval for asymptomatic carotid artery stenting. Well, how do we take this?
Yeah. Well, I'm there are two pieces there, I think, to pull the thread on. One of them is the TCAR versus CAS. And I'm still, I still am not sure that that's been adequately tested. I don't think that that's a done deal. I think that those studies, they're not the same as a randomized controlled trial. I mean, propensity matching is a technique to reduce that, to reduce some of that variability, but it's still not quite as good as a randomized trial. And then I also wonder too about operators, and who's doing these studies. And that there are, if arch manipulation is a major cause of stroke for CAS, well, then people that know how to get into carotids quickly and are going to have fewer complications. And so I think there are some apples and oranges there. I do think that from a sort of a mechanistic point of view, having control of that carotid and having retrograde flow does offer some advantages, but you can achieve the same thing transfemorally. And that was Juan's device, and I think and I think covered stents personally are also going to come into play, because a lot of the microemboli occur post-procedurally, even in the TCAR patients as well. And I think
we've been talking about mesh and pore sizes for decades now.
Right.
What can you say about TCD
Yeah.
for microemboli
Yeah.
with both of the techniques now?
Well, I think there are two things there. TCD does identify patients at high risk there's a really nice study by, names at the tip of my tongue now, but by a neurologist, David Spence from Toronto Western, where TCD and asymptomatic populations identified a group at high risk for stroke on medical therapy. So, Mike, that is sort of a plaque biology that does have really good potential as being an indicator of a high risk asymptomatic population. So that's one role for TCD, is potentially as being one of the major tools for identifying the high risk for stroke asymptomatic population. But the other thing for TCD, just like you were saying, is that it has great utility for helping as an adjunct to these procedures to identify how to improve, how to reduce risk. Like people have done TCD studies looking for microemboli, which can be bubbles, but they can also be pieces of debris during the different stages of a carotid angioplasty and stenting. And there are TCD emboli with catheterization of the vessel, with crossing the lesion, with angioplasty and stenting, with the protection device. And so studies where you're using that and I think even Juan did some of these with flow reversal and saw a dramatic reduction in TCD microemboli. Yes. And I think it's a good surrogate. It's a good surrogate that can help us refine the technique. Absolutely.
So I'm grateful for that topic to one of our audiences. There's another question from one of our attendees in which they've asked, what's your opinion on management of carotid webs, ipsilateral TIAs or stroke?
Yeah. Well, I'm kind of, as I'm sure it came across, I'm a pretty conservative guy, and I really do like to see the evidence. And before, I'm not an early adopter, and I think that the current world of carotid web intervention is dominated by early adopters because really there's not a lot of evidence there yet. And I mean, frankly, I've never seen a symptomatic carotid web personally. I don't deny that could happen, but I just I've seen a lot of carotid webs, and I'm really not sure that they're a frequent cause of stroke. And if I had a patient with a web and really everything else crapped out, in terms of a source for their stroke, I'd probably treat it, but yeah, I think that I'm still waiting on that one.
So maybe as we're wrapping up your thought experiment on how you design the perfect trial of what you want to see for, for techniques and choosing asymptomatic patients that are going to benefit.
Oh, well, I think really so if CREST-2 and ACST2 show no benefit for endarterectomy or stenting for asymptomatic patients, then that opens up the world for natural history studies, where we can do longitudinal studies looking at plaque biology, TCD for a microemboli, hemodynamic factors, and we can identify which of these or which combination of these identify a high risk for stroke population, and then test intervention in that group. I think if CREST-2 and ACST2 show a benefit for intervention, then it's going to be a lot harder to do that study because people are going to treat those patients. And
yep. You're done.
Yeah. Yeah. So the way I would design the perfect study is to have CREST-2 fail to show a benefit.
I think with that, we wrap up. We're very grateful for you for taking time and reviewing all this data for us. And I'm excited to archive this so that everyone else can see it as well. Thank you. And thank you, everyone, for joining us.
Yes, thank you all. Yeah. Merry Christmas. Happy holidays.